Chapman and the other members of our REOP committee for putting together a wonderful presentation tonight. Our goal at the Washington State Orthopaedic Association is to provide value to our members, and we do that in terms of advocacy, education, and perhaps most importantly, creating a community for our orthopedic physicians in Washington State to work together to continue to further care for our patients and have a venue to communicate and enhance that community ongoingly. So I think tonight is a perfect example of that. Dr. Chapman and the group have worked very hard to put together an excellent panel of speakers, and appreciate everyone joining on tonight. And please continue to support our Washington Orthopaedic Association as we work to deliver value to you. And with that, I will turn it over to you, Jens, to introduce our speakers for the evening.
Thank you, Kevin. Much appreciated support from you and our board. I want to recognize Mia Hagen from UW and Ed Arrington and Roger Blauvelt for all of their contributions. And it's cool to have John Keefe there, who will also lend expertise in all my very neat board members. This is an exciting evening to put together because we all face a number of questions and concerns, and we want to pull together topics from three different, very different arenas that affect all of our practices. One is stress fractures, and we have Dr. Bruce Twaddle from Auckland, New Zealand, who is a member of the International Olympic Committee. He was, for FIFA, the sports director. He was a UW faculty member, and when the Sports Medicine Center at Husky Stadium opened, he was the faculty member who opened that up and was there for 3 years. And he's a sports medicine doctor, and I've been so impressed with many of his areas of work, but particularly his stress fracture approach really intrigued me as a spine surgeon. It's a far more expansive view, very comprehensive, as he is as a surgeon, very to the point, and I think, and I hope, very helpful for all of us, as we as orthopedic surgeons should own the bone and should take a greater advocacy for this. Our follow-up speaker will be Dr. Alexis David. She's from Bellevue, Washington, and obesity is something that we all face, and many insurers just deny elective surgeries nowadays flat out. But she impressed me greatly and inspired me to kind of take a different approach, not a confrontational, not a shaming approach, to how to engage our overweight patients to try to make a difference. So while this is obviously a big field with many different pharmacologic and surgical options, how to engage and approach our patients to make them collaborators in their quest to get better, really, I thought was very interesting. And our group thought this might be of relevance for all of us to kind of have a new form of approach towards our patients. And finally, again, a former fellow of ours at Harborview, with Drs. Anderson and myself, Dr. John Steinmann, is going to talk about something that we all are interested in. Orthopedics is unique for its entrepreneurship and inventionalism, more so than most other specialties. And he's done it all. He's raised a very successful family as a family father, but he has been a very successful operator of one of the largest groups in Redland, California, and SoCal, Arrowhead Orthopaedics. He runs ASCs. He's formed an orthopedic equipment company. He's sold it now successfully to Kyocera, and he became a nationally recognized name when it came to physician-owned distributorships. And he was on Capitol Hill repeatedly talking to various Senate finance committees about why and how we can be distributors. So he's a very long and successful track record in orthopedics, and how to kind of be successful entrepreneurs in this very divisive climate was, I think, something that nobody better than John Steinmann can talk about. All have Washington ties or practice here, so I thought this is a great combo of speakers, and I want to thank them all for coming here. Without much further ado, we'll turn the microphone over to live from Auckland, New Zealand, to Bruce Twaddle to educate us about what to do about stress fractures and how we can own this part better than what we've done in the past. Thanks all for being here, and thank you all for visiting tonight.
Well, thank you, Jens, and I appreciate the opportunity to speak to you all. And as you can see, I have been integrally involved in the International Olympic Committee medical panel. And as part of that, I've developed a significant and long-standing interest in stress fractures. And in the time available, I hope to re-educate you in a much more sophisticated way of looking at things. So the goals of this talk are talk about who gets stress fractures, try to redefine some of the science of how they occur, and probably get rid of the myths that currently exist. Talk about the treatment options, and discuss finally for that something we're interested in, which is the surgical indications and techniques. So traditionally, in the 1950s, the model was suggested that a stress fracture was the result of osteoclastic overactivity, and the ability to lay bone behind that osteoclastic activity couldn't keep up and you developed a stress fracture. Well, that sadly is an urban myth. There's very little scientific evidence to support that. And if you look at the information available, it has no relevance to what stress fractures are and when they occur. And most of the work we see of scientific nature is done in military recruits. So if you look at military recruits that had bone scans in the Israeli army and they monitored stress responses very early, some of them were detectable within 48 hours. 64% of those who were going to get stress fractures had bone scan reactivity within 1 week, so you could identify who they were. 33% of the recruits got some kind of stress fracture response within a month. And if you look at the osteoclastic osteoblastic model, that resorption doesn't begin for at least 30 days effectively. So in the recruit studies in the Israeli army, everything had happened before the suggested model could kick into action. So who gets stress fractures? So there are military recruits, and that's where a lot of scientific studies have been done. Endurance female athletes is a group that became recognized in the 80s and became a focus of the International Olympic Committee medical panel in the early 2000s. Pediatric athletes at the time of growth spurts, where they become relatively osteopenic, are at risk. And then we get the elderly, particularly female patient or female athlete who has an insufficiency fracture, either from rapidly increasing their load or just trying to do too much for their own skeleton. And then there's a whole group of various people who decide to rapidly increase their training intensity, and then what I call a born-again athletes who take up CrossFit in their 40s or some other activity to rediscover their youth, or vicarious champions, which are usually the parents of athletes or children they want to be athletes, and so to join their child's foray into sports, the parents suddenly take up activity. So those are kind of the people we see who get these problems. But if you look at all stress fractures, there are very different categories, and to put them all in one box is completely irrational, really. So there are what I call metabolic stress fractures, there are what I call biomechanical stress fractures, and there are what I call biological stress fractures. And we'll go through each of those in more detail. What we don't want to do is put them all in the same box. So the first thing you want to do is work out which one or combination of causes you are dealing with. And this is a study that very clearly demonstrates the differences that exist. So this looked at Navy recruits who got tibial stress fractures to try and determine if there was a difference between those that got stress fractures and those that didn't from their tibial morphology. And what you can see is that in the males, the group that got the anterior tibial stress fractures predominantly had a relatively narrower tibia and a much greater cortical ratio. So they had a very thick cortex and a relatively thin bone. Whereas in the females who tended to get tibial stress fractures in the proximal and distal tibia, they had the same or relatively greater diameter of their tibia, and they had a narrow cortex. So they have evidence of insufficiency of cortex. So what you can see already from this very useful study is that there is a clear difference between stress fractures that occur in the males and stress fractures that occur in females. Simplistically, most stress fractures in females are insufficiency fractures of cancellous bone. whereas most stress fractures in males are a focal unicortical disease with occasional failure and propagation through the rest of the bone. So that's simplistic, but it allows us to start separating out our patients in terms of two very clear etiologies. So we're all aware of the female athlete and the female athletic triad, which really came popular at the time of the LA Olympics, and a focus for management of this problem, where they had an eating disorder, they had menstrual irregularity, and they tended to have osteoporosis. And these injuries and fractures usually occurred in people who were addicted to running, as they say. Excessive running was usually a component of it. So this is what we call a metabolic stress fracture. There is a disorder of your metabolism, which is often self-induced and so can be self-corrected. It's become a focus of the International Olympic Panel, and with the work of Margot Mountjoy in particular, looking at relative intake versus relative outtake. So they talk about relative energy deficiency in sport, which is REDS, or low energy availability. So these are the two catchphrases for this metabolic group. And these are people who relatively seem to be eating reasonably normally, but because of their excessive training and output and their fear of not training hard enough, develop a deficiency of energy input, energy availability. And the way they look at that, it's a very sophisticated model. They look at their energy intake, so what they calorifically take in, and then they work out their excess exercise energy expenditure based as a ratio of their fat-free mass. So this is a very sophisticated number, which you can tell how much someone should be taking. And you should be sitting at a number of about 40 to 50, up to 60. And if you're a Tour de France cyclist, you're down to 8. So you're very energy intake deficient. And the work of Margot and her group of experts in this area have now expanded this triad into this whole metabolic group and immunological and physiological issues you should be looking at in your athletes that seem to have this metabolic disorder, where they're either not eating enough or eating sufficiently, but exercising way greater than the energy they are providing themselves for. So what stress fractures does this relate to? We look at these type of fractures: pelvic ring stress fractures, the medial tibial stress fracture proximally and distally, the compression side of the femoral neck, the calcaneus and some navicular fractures, and the so-called periarticular insufficiency fractures. And these are almost exclusively fractures that occur in the lower extremity, and all the fractures that occur above the knee, apart from tension-sided femoral neck stress fractures, usually fall into this metabolic group, and you need to look at their diet. You need to get them assessed by an appropriate expert to reduce their training relatively and increase their intake. So the next type of fracture we're dealing with is the mechanical failure stress fracture. And these occur in a very small and exclusive group of bones. So the amount of load applied exceeds the mechanical strength of the bone. And that's difficult to do. That's difficult to do in the tibia. It's difficult to do in most weight-bearing bones. So the thinner the cortex, obviously, the greater the risk. And it occurs in bones that are disproportionately loaded in people like Navy recruits and Army recruits. So the classic March stress fracture of the second and third metatarsal is what we call biomechanical failure. So you've just loaded that bone greater than it can tolerate. Rib stress fractures in rowers is another fracture that is probably in this group, where these guys are rowing 16, 20 kilometers a day when they're really expanding their training load, and the pull of the latissimus dorsi constantly on the rib on one side in single oar rowers is where the problem occurs. In the pediatric lumbar spondylolysis, this is probably the etiology of the stress fracture, although it transitions into what we're going to call a biological stress fracture in the adult population. And then, of course, if you've got an osteopenic skeleton, if you load that skeleton, you can exceed its biomechanical load. So these are very distinct, thinner bones, loaded more than they want to, and the bone fails. So not necessarily due to their intake, but certainly diet and calcium supplementation and calcium metabolism can play a role in managing these patients. So then we get on to the most interesting group, which is the biological stress fracture. So firstly, you've got to look at the other causes in your athletes, but the fundamental characteristic of this stress fracture is that it's a unicortical disease, and it almost always occurs at a watershed area of circulation or in bones or parts of bones with poor blood supply. So what I will tell you, if you have a very thick tibial cortex, the last outreaches of your circulation are the anterior cortex and the middle third of your tibia. So it's a watershed area that you're getting these problems in. So this is the biological stress fracture. And here you see examples. All the so-called Jones fractures of the proximal third of the fifth metatarsal start off with this unicortical disease that you can see here. It's the same with the anterior tibial stress fracture. And the important thing to look at is how far through the cortex this area of what we call a fracture has progressed. The failure or the fracture itself is a propagation of this defect. It's like sawing through one side of a pipe, and then, so the fracture line that progresses from there is unpredictable in its alignment. So you have a very straight line in the cortex, and then this failure of the cancellous bone as a secondary event. So you can see it in very chronic navicular stress fractures in adults. You see it in the Jones fracture. These are classic examples. And there is an animal model for this, which sadly they've hidden away, or not sadly, because it wasn't necessarily that kind to the animals. But in the 1980s, they did this study at, I think it was Duke University, where they put rabbits in an electrical cage, and they induced running and jumping by stimulating the floor of the cage every 20 seconds for 2 hours a day, 6 days a week for 60 days. And they looked at what happened, and this turned out to be a phenomenal model for generating these biological stress fractures. And basically, the changes they saw were all related to a circulation under stress. So the blood started to coalesce together, the vessels became dilated. You went on to get these death of your osteocytes because they ran out of blood supply, and these cavities formed, and these cavities became joined together, and you eventually got these cracks through dead bone. So it was literally the formation of ivory, and the ivory eventually died. So this is what you see, this circulation under stress, where you lose the osteocytes, the vessels get bigger. And the interesting thing is, after I spoke on this as the guest of the Norwegian Orthopaedic Association, they decided to pursue this and check out it histologically. And they did the study where they core biopsied these anterior tibial stress fractures. And what they found was that it's not a fracture at all. It's a line of dead bone in the most least perfused part of the tibia. And the fascinating thing from this study was that 7 of the 8 patients they did this in, it was curative. It got rid of their symptoms. One, unfortunately, got enthusiastic about his loss of symptoms and went back to activity and sustained a fracture. But so there's 2 flip sides to getting rid of the pain in these patients. So what we see is this ischemia and anoxia leading to osteocyte death and osteoclastic activation. So the biological stress fracture is related to a circulation under stress. And these are the fractures that we see it in: the anterior tibial stress fracture, the base of the 5th metatarsal, some naviculars, and the tension side of the femoral neck. They're all watershed areas where this fracture occurs. In terms of imaging, for me, the imaging study of choice is a SPECT bone scan. because it gives you an idea of activity, and it also gives you an idea of whether they have this unicortical disease. So that's my go-to investigation in most patients who have a stress fracture that isn't responding to the usual treatment. The trouble with the grading system is it doesn't separate the groups out. So all these patients where they have a fracture line on T1 or T2 are a different group of patients, and they will behave differently. So all the classification systems are somewhat flawed in terms of how you look at their imaging. So what about the treatment? As you can see, like this Aussie Rules football game, it is a potpourri of options, and none of them are well proven because they don't necessarily use the right treatment for the right type of stress fracture. So we have three clinical scenarios. We have the initial response where they present early. We have the obvious cortical stress fracture, which is a biological problem. Or we have an extension or propagation of the cancellous bone, which can be biological, can be mechanical, can be metabolic. So again, it depends which type of disease you're dealing with. The goals of your treatment are initially to reduce activity, identify physiological failure, be that dietary or biological, allow metabolic processes to catch up and see what happens. So feed those that are starving, reduce activity in those that are doing too much. Then you reintroduce activity and see what happens to your patient, see what happens to their problem. And then in this milieu of patients that you're seeing, you want to identify those patients that are going to do badly and intervene early if you think you need to. And then there are all the adjunctive treatments that you can give to these patients. And again, changing activity in those that have fractures is unlikely. They're not going to get to 16 weeks. They're not going to get to 20 weeks. They're probably going to need some other intervention. So what about training modifications? Well, in Israeli military recruits, they decided to take every third week of their basic training to make it non-impact related. And they had a significant change in the biomechanical stress fracture incidence. Unfortunately, that didn't change what they did after the study. But reducing activity in patients with biomechanical stress fractures definitely seems to make a difference. And it's a very useful step in basic training. Orthotics have been shown to be helpful as a preventative form of treatment. So in military recruits, if they gave them orthotics before they started basic training, it significantly reduced their evidence of their incidence of March fractures. There is no good study showing if we start that once they're getting their symptoms, will it make a difference? Shockwave treatment has been shown to be helpful, but the science behind it is difficult because the way they deliver the shock is very different, and probably using an electrohydraulic shock is helpful. But unfortunately, in stress fractures, you need to give them 8,000 shocks, which usually means they need a general anesthetic and isn't well tolerated. Pulse low frequency ultrasound is another treatment modality that may be helpful, but there's very little scientific evidence to support its use, and most of the good studies are in animal studies. I've had some experience with the use of pamidronate, which is an intravenous biphosphonate, and found it very helpful. Unfortunately, patients do get a flu-like symptoms with it, and in the age of COVID, they've been less attracted to having it as a form of treatment. It is, by good luck more than anything, shown to be the biphosphonate that selectively affects cortical osteoclastic activity, which is probably why it's most effective. So fortuitously, it may be the right drug. It has to be given intravenously, and we give an infusion every week for 4 weeks. You get 3 groups of patients, though, those that have almost immediate response, and it's very helpful in rowers with rib stress fractures. And a group of those, whose symptoms go away within 7 to 10 days. There's a group that have progressive improvement over 6 weeks, and a group where there is no response. So you can tell very quickly who's going to be a success or not. We looked at the various sites we use this in, and this is in a series of nearly 90 patients. So in the navicular stress fractures, they didn't do well. You can see in the tibia that in the proximal and distal tibial fractures, they were early responders, but in the anterior tibial cortical stress fractures, they did badly. Compression side of the femoral neck, they did well. Tension side, they did badly. So again, it depends which stress fracture you're dealing with, but all the rib stress fractures got an excellent response. Synthetic parathyroid hormone probably enhances normal bone healing, but it is not necessarily the go-to cure in stress fractures, although it's become very popular in professional athletes. We don't really know how to control it, and it does have a risk of osteosarcoma in adolescent patients, which is the group we're usually dealing with. Parathyroid hormone, as I said, enhances normal bone healing, so it's probably useful in metabolic and biomechanical stress fractures. So hyperbaric oxygen is the other modality that I think is helpful, and there's been very little study on this. I've used it in a group of patients who've got these periarticular subchondral fractures. This is 3 months follow-up, and I've found hyperbaric oxygen has been extremely helpful in rapidly resolving their symptoms as long as the articular cartilage survives. So what about surgical intervention? I'm not going to dwell on this, and I'll race through this so we get to the final slides as my time is up. But in fifth metatarsal stress fractures and anterior tibial stress fractures, I'm aggressive. So I want to compress everything and get rid of the bad bone if I have to. We know the fifth metatarsal is a watershed area, and I like to put a 3.5 cortical screw down the fifth metatarsal percutaneously. That way I get all this purchase on the distal bone and excellent compression, and this is almost a guaranteed cure. The anterior tibial stress fracture is more difficult to treat. It's the worst behaving animal. And what I like to do is aggressively debride the area down to where that cortical line goes to. And if it goes through the cortex, I take out the whole cortex. My treatment varies on how far through the cortex it goes. So if it's only partly through the cortex, then I take the bump and put a plate in to support it. If it goes all the way through the cortex, then I take the whole on-block part of the cortex out and put a nail in. So here's some examples which I'll get to. Here's an anterior tibial stress fracture, partly through the cortex. I've debrided and put a plate on. With intramedullary nailing, you need to excise the block. So here's the type of excision I'm talking about. It's been bone grafted. Usually I take bone out of the femur, and then you watch this over time as the fracture heals. So early presentation, they need a metabolic and physiological workup. You need to address the metabolic issues. You need to look at their biomechanics, consider orthotics. You need to modify their exercise and see what happens. If they have symptoms for greater than 6 weeks and an obvious line on the X-ray, you need to look for medullary extension and consider surgery. If they've been there for a long time, you want to address the metabolic issues, change their exercise pattern, consider surgery for high-risk stress fractures, and these other modalities can be introduced depending on what's available at your institution. Those that are going to fail, you need to be aggressive about excising the bone if it needs it and providing compression and support if you can. We're looking at these particular stress fractures for metabolic fractures, particularly the insufficiency fractures in the elderly. You want to address their issues, allow the fracture to heal, and gradually reintroduce activity. For the biomechanical stress fractures, you want to address those mechanical issues, allow the fracture to heal its normal bone healing, and then try and alter their biomechanics. And for the biological stress fractures, which are difficult animals to treat, you want to do excision of the bad piece of bone. Surgical treatment needs to change their loading, and be careful about propagation into cancellous bone. All right, that's a lot of information to take in. I hope that it's helpful to those people listening.
That was awesome, Bruce. Thank you so much for interrupting a surgery list and joining us. Kevin, as our president and oncologic surgeon, any thoughts before we go on to our next speaker? We don't have time for many questions, unfortunately. We had some in the chat room. Any thoughts, Kevin?
Yeah, thank you, Dr. Twaddle. That was terrific, very informative. The pomidronate, that's an interesting idea. Two-part question. When do you decide to do that? And do you have any follow-up or concern whether that may actually lead to further stress fractures down the road by disrupting that bone?
Well, that's an interesting question. So in fact, to answer your second question first, pomidronate is thought to be protective because, so I do all my pomidronate management is in company with an endocrinologist who does a full endocrinological workup on the patient before they're treated. When they present early, they always get unloading, and I've managed their load and see what's happening. And after 6 weeks, the thing is, these patients usually present after 2 to 3 months of trouble. So for me, at 6 weeks, I will consider pomidronate in certain fractures that I know are going to do well and in motivated athletes. So for anyone who's a collegiate or Olympic rower, normally a rib stress fracture takes you out for a minimum of 3 months. So that's a group of patients that I intervene in early. If you're someone who's a high intensity runner with a fracture of the pubic ramus, then I'm highly unlikely to treat you because that's way more a diet metabolic activity problem than something I need to treat with pomidronate. So it's horses for courses, but certainly rib stress fractures. And the other stress fracture that has been very helpful in is the compression fracture in the femoral neck in female soccer players and athletes such as that. That's really been, it's amazing to me how quickly they get better. They get a test dose of 30 milligrams for the first week, then 60 milligrams for the successive weeks. After that, they feel very sick, like a flu with the first treatment, which you need to warn them about. And it stays in their skeleton for 2 to 3 years. So it literally protects them from the problem arising again.
Outstanding stuff. Hey, we must move on, but many more questions. Maybe we have time at the end, but thank you so much, Bruce, for interrupting a surgical schedule and joining us. And you're just a true treasure to have, and really always appreciate learning from you. I'll look at this in slow-mo later to absorb all the information you had there. So thank you. Alexis David is coming to us from Bellevue, Washington. She's an internist, and she has impressed me with a new approach towards engaging patients with obesity challenges. This is something that we obviously really face daily, whether it's hips, knees, spines, it doesn't matter. And we tell them to lose weight, and this is frequently a pretty frustrating proposition. And the thought of telling them to lose weight before surgery doesn't work, and after surgery doesn't work. So Alexis, tell us how we can approach those patients and what we can offer them in the future to make headways.
Hi, well, thank you for inviting me to talk and to share my information with you. To get started, the obesity challenge, as you see, it's hard to manage this. And I'm family medicine by training. After 13 years, became certified in obesity medicine and opened my own practice, medical weight management in Bellevue. And I'm the president of the Washington Obesity Society. So I'm excited to talk to you guys today. What we're seeing is, a lot of us in medical school, we weren't taught other than what fat does. It just stores energy. But what we've learned now is it's a much more complex organ system than that. And the disease of obesity is a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease, where an increase in body fat promotes adipose tissue dysfunction or adiposopathy. And there's also the abnormal fat mass physical forces that result in an adverse metabolic, biomechanical, and psychosocial health consequences. Most of you are familiar with the categories of BMI. I just want to use, patient first language, and the overweight category of pre-obesity is what we're trying to use the term, much like pre-diabetes for patients with diabetes. And we also look at body composition, what percent of their weight is from body fat, as well as their waist circumference. As you're familiar, there's an increasing trend in the amount of people who struggle with this condition. And the 2017-18 NHANES data showed that more than 2 in 5 American adults have obesity. And what's alarming is that practically 20% of children ages 2 to 19 also have obesity. And by 2030, we're predicting to have over half the population with obesity, with greater than 25% of them having a BMI over 35. So, why is this important? It affects every organ system in the body. And I could give an hour-long lecture just about that alone, but we're going to focus primarily on osteoarthritis. How does this, why does this affect? There's the mechanical stress from the increased weight that causes the structural damage, as well as the metabolic effects. There's increased inflammation, cartilage degeneration, and bone remodeling that occurs. And a meta-analysis of patients with osteoarthritis showed that someone with obesity has increased pain, longer-term disability, and greater complications following joint replacement. So, it's very complex and complicated as to why this is happening, but there's anesthetic concerns, physiologic, pharmacodynamic changes affecting our pain management, functional capacity, as well as the postoperative recovery. But that's not the primary reason I'm talking with you today. As you guys are aware, you guys are asked to help a patient optimize their health before an elective joint replacement. And in 2015, the AAOS came out with these guidelines. And when I review them, I think they're pretty straightforward, yet difficult to put into practice. And often it can be difficult for you to talk with your patients about it. What we've learned is that, there's not much data out there that may necessarily show a significant improvement in outcomes, because a patient with obesity has many medical conditions. And when we focus primarily just on weight loss, we may not be addressing all of the other conditions or complications associated with that, the reason why there's more complications. And if you try to have somebody just on their own, just lose weight, just go exercise, eat less, move more. Well, it's much more complicated than that. And what a study shows is that maybe about 7% of patients are actually able to achieve a BMI less than 40 with modest lifestyle modification alone to be able to achieve that surgical goal. And so when they are hearing from you, just lose weight, for them, they've been trying their whole life trying to lose weight and it doesn't work. Well, why do we want to focus on weight loss? A lot of patients with extreme BMIs or severe obesity have a lot of health risks. And a lot of times it can be overwhelming just to think about how much weight do we actually have to lose. But what's exciting and what I try to help get across to my patients is that modest amounts of weight loss can have a significant impact in health gains. With just a 2.5% or greater weight loss, we see improvements in glucose metabolism, which can result in less surgical, infection complications. With 5% or more weight loss, we have a significant impact on the quality of life score, decreased depression, improvements in mobility, knee functionality, a long list of things. And when we reach 10% or greater, we see a decrease in the non-alcoholic steatohepatitis, sleep apnea, and most importantly for you, inflammation. And when we are able to achieve a greater weight loss, like 16% or greater, we see a decrease in cardiovascular and overall mortality. So how do we go about this? Patients are there to see you for their joint pain, and they want to be treated for their joint pain. And how do you approach somebody to try to talk about their weight in a challenging situation? And most importantly, what I want you to take home is to use patient-first language. There's a lot of stigma and bias in our culture, society, and especially in our healthcare facilities. And thinking of this, really changing the way the words we use matter. And people want to hear from you and learn from you what you have to say. And it's hard when you use terms like obese, morbidly obese, and fat. So how can we effectively treat this? Well, you have a patient there to see you when they're having a joint problem, and you want to talk to them about their weight, and they already know they have a weight problem. Don't make assumptions that they haven't been trying to lose weight. But first off, it's important to share with them what you know about the complications their weight has with their joint health. And so first off, ask permission to discuss their weight with them. Give them an assessment based on their BMI, and advise them about the health risks that are associated with that increased weight, but also share with them that with modest weight loss of just 5 to 10%, you can see a significant reduction in health risks and improvements in health outcomes. Agree on what may be a realistic weight reduction and expectations of that, and then help to arrange or assist them. Instead of walking out the door, lose weight, come back when you see me after you've done that. They're like, thanks, I've been working on this most of my life and it's still here. So how do we effectively treat weight? And most importantly, the disease of obesity? Well, from a medical management perspective, we have the 4 pillars of approaching, primarily focusing on nutrition, activity, behavioral counseling, and pharmacotherapy. And my surgical colleagues will very effectively utilize the bariatric surgery and other endoscopic procedures. What is a good nutritional approach? So what do you say to somebody? Like if they wanted to say, well, what do you think I should do? Most of our patients with obesity, believe it or not, suffer from malnutrition. The physiologic processes going on, and they're constantly storing energy, and they're constantly feeling hungry and may not have enough energy in their bloodstream to support the amount of energy required to move their body mass. So we have to make sure that they're nourishing their bodies first and foremost with getting enough protein, produce, whole foods. And the most important meal plan is the one that they can stick with. There's a lot of fad diets out there. And I always talk to my patients about, I don't want you to be on a diet. I want you to make a lifestyle change because that's what's going to be most sustainable. So the best eating plan is one that is going to work for them and their lifestyle. And most commonly, we struggle with nighttime eating or snacking. So if you want to give them a couple quick tips is nourish your body with healthy whole foods. Make sure you're getting enough proteins and produce, and try not to eat after dinner. And if you can get them started with that, they can see a significant impact and difference in their weight and metabolism when done on a consistent basis. What I really think you can be most helpful with is helping them to modify their activity. If their activity is limited because of their orthopedic condition that they're seeing you for, well, they see that as an essential part of their weight loss program, and it's affecting their ability to continue to lose weight. So helping them to limit the amount of time they spend sitting down, and just helping them to get started. Okay, here are some things that you can do. Like, what can you do? And what I work on most people is, well, let's do a little bit more than what you're doing now. If we can just get 10 minutes at a pace, and a pace that you're late for a meeting, and if you can do that a couple of times a day, if you have somebody that's primarily in a sedentary position most of their day, that's going to help improve their resting metabolism. And it has been shown to be clinically significant in helping their overall, energy use. And we also want to work on muscle groups and improving their functional status, addressing their behavior. That's getting into more complex things that I'm not sure you may have time with in your practice. But obesity, first off, I want you to recognize is a disease itself, and it deserves to be treated like one. We do have many different medications available to us now. There's been medications available for years, but they've had very mild to modest results. What we've seen in the media a lot lately is the exciting medications in the GLP-1 receptor agonist class. where we're seeing an effect not only in multiple areas in our organ systems and body, but also crossing the blood-brain barrier, increasing the satiety signals, and we see patients eating less. It also helps to optimize the glucose metabolism, treating the insulin resistance, and decreasing the storage of fat. You can see with semaglutide, we get about 12 to 15% and often more weight loss, and with the treatment of that. There's a lot of anticipatory guidance that needs to be given with that, and there's a lot of side effects that occur. What's even more exciting is coming out the market soon, currently only FDA approved to treat type 2 diabetes, but by the end of the year will be FDA approved to treat obesity, is tirzepatide. That is a combination GIP and GLP-1 receptor agonist, working specifically at the CNS tissue, as well as adipose tissue, to decrease the desire to take in certain foods, as well as how our adipose tissue is metabolizing the energy we're using. And you can see at the bottom, intensive lifestyle therapy and change, or what I call the white knuckle approach, living in a constant state of restriction, we kind of max out at about a 6% weight loss. So what are you going to do to help your patient who is seeing you and needs to have surgery? Well, we want to really get them into a really effective, not just weight reduction, but a health optimization program. A prehabilitation is what I like to think of it, and focusing not just on, how much weight, but what percentage of weight can we get down. And a 5 to 10% reduction is going to get you mostly what you need. We want to prioritize maintaining a healthy lean body mass, increasing their functional status, increasing their pulmonary function. When we get that 10% or more, things in life for this person is just easier to do. You are going to also see less health risks and overall complications. Oftentimes they are going to need anti-obesity medications, and they may need to be managed perioperatively. And, we most of the time do need to continue post-operatively, although there are some studies out there using short-term low-dose phentermine with good success. If your patient is considering bariatric surgery as a tool to treat their weight, to optimize their health prior to having a joint replacement, they do need to plan for 6 to 12 months recovery from bariatric surgery before having any other kind of surgeries. So I do want to share with a case with you. I know we're getting close to time, but this data represents a patient that I did see in my practice. And like many of my patients and your patients, they've been struggling with weight and severe arthritis. She needed both hip and knee replacement. When she came to see me, she had already been working with a nutritionist at her physical therapy office for about 3 months and had maxed out at about 12 pounds weight loss. She was tracking every day, and I believe she was doing everything she was advised, but she just maxed out. So what did we do? So she came to see me. This is her weight craft data. And, I congratulated her on the work she was doing. We discussed the disease of obesity and got her on the right medications for her, which was semaglutide. After about 2.5 months, we got her to her goal of that 30 pounds or 10% weight loss that her orthopedic surgeon had given her. She had a successful right hip replacement, and she continued to lose weight. We continued to meet and work together. Her mobility did improve, but unfortunately, her knee became an issue. And so about 4 months or so later, she had her knee replaced after she had lost an additional 10%, close to almost 60 pounds. We've continued to work together. Her mobility has continued to improve. She's able to walk down the airplane aisle without going sideways. At 1 year, she's down almost 30% or 81 pounds. And her most recent checkup earlier this month, we're over 40% weight loss or 122 pounds. But as you see here, it's not a straight line. For her, it does look like one, but there's plenty of moments in time where there's been a struggle. But she's pretty happy right now. She's able to move. She's able to be more active and have a much more better quality of life. So I could talk a lot longer. I know we're getting close to time, but obesity does require an effective long-term management. Can you imagine? I have had patients who've come to see me primarily focused on that knee or hip replacement. We get them to their goal, and then, it gets hard because once they've had that joint replaced, they don't feel the pain as much and they become less focused, even though I try to reinforce with them the need to continue treatment to maintain weight loss. The process of metabolic adaptation is not in our favor. I always talk to patients, our bodies were not designed to lose weight. It was designed to maintain weight or to gain weight to prevent us from starving to death due to some, old adaptations that helped us to survive back in times when we did not have food readily available. So this I'll skip over. I won't spend too much time. You can look at it later, but there was a study that did show that people who were able to lose a significant amount of weight and keep it off were able to decrease the risk or delay the onset of osteoarthritis. All right, so to summarize, the overall effect of 5 or even 10% weight loss, improved functional capacity, decreased mortality, increased lung capacity, cardiac output, reduced cardiac events. We have a generally decreased inflammatory response, RAS activation system, improved joint mobility, decreased incidence of chronic pain. And I would also say there's a decreased sympathetic activity. So their stress response is improved. And this person is feeling much better. They're feeling great. They may still have the disease of obesity, but they're in a much healthier place and life is just easier for them. So what can you do? You just summarize, acknowledge how difficult losing weight is, just have that. It doesn't take long to talk to them about it. Just say, I know that it's hard and it's a lot different than what even I was taught in medical school. And it is more than just calories in, calories out. Key components involve healthy nutrition, nourishing your body with healthy foods, getting healthy activity in, whatever that may be for that person in front of you, working with someone who can help manage meds or even consider bariatric surgery. You can find a specialist in your area. I've listed some resources here: the Obesity Medicine Association, American Board of Obesity Medicine, the Obesity Action Coalition, and I'm proud to say the Washington Obesity Society, although we're a very new, fresh, young group, and we are working on that resource for you. So just remember the 5 A's. Ask permission. Don't assume. Advise based on modest outcomes, get significant results. Agree on a healthy target and assist with appropriate referrals. Please use patient-first language, take a non-judgmental approach. And remember, when you treat obesity first, not only does their weight improve, their quality of life improves, and so many other medical complications. And more importantly, from your perspective, a really good prehabilitation program can reduce length of stay, improve patient satisfaction, reduce post-operative pain management, and decrease readmission. And thank you.
Thank you, Alexis. That was really helpful. And again, just denying orthopedic care for our patients as orthopedic surgeons is not enough. And I learned a lot from when I met you a couple of months ago, just to ask for permission to talk about weight. And that alone changed the whole approach that patients now give me when I address this very sore and difficult subject. 2 quick questions, 1 sentence answer, maybe if possible. Medical management, monitoring down the line, and rebound, return of obesity. Any thoughts on that?
Oh, yes, it's a chronic condition. And I talk with my patients from day one that this is a chronic condition that is prone to relapsing and reoccurring. We have moments, just like cancer or other medical conditions, we have moments where it's well managed and optimized. We have others where it's not. And I do talk to them about the need for ongoing management from the get-go. The things you do to lose weight, for the most part, need to be continued long-term to maintain weight loss. And oftentimes they don't want to hear that. Well, I don't want to be on a medicine. But what I often can say is like, well, we do need to continue the treatment. And so, if you have hypertension, you need medicine to treat it. If you remove the medication, the blood pressure is going to go back up. The same thing happens with weight. The same thing happens. So.
Great. Must move on. Thank you so much, Alexis, and this will be a much watched video also, and thank you for our audience members. John Steinmann, last not least, I apologize for everybody for running over, but this is a superb outlook lecture on a strong suit of orthopedics, and that is entrepreneurship. Is there a role for it now? Where is it? And again, you'll get a logo for the CME thing at 7 o'clock, so in about 5 minutes, but we have received permission from Angela to run a little bit over. So John, go ahead. Thanks for being here, and thanks for waiting, and thanks Alexis for a great lecture.
Okay, yeah, thank you very much, Jens. I'll get going and get us through this. By way of introduction, I'm an orthopedic surgeon, did my fellowship University of Washington, very appreciative of that experience. I've been in private practice for 31 years. I'm the president and CEO of Arrowhead Orthopedics, 32 surgeons, 10 offices, 3 surgery centers. I have some entrepreneurial ventures that I've done. I've enjoyed it very, very much. I'll go through a couple of those examples with you. And in the past 20 years, I've been able to create over 200 million in shareholder value while conferring in every single case value and cost savings. And that's going to hit on that a lot because that's a critical issue for us to focus on. Bear with me for a second. So what does it mean to be an entrepreneur? I hope to stimulate some in the audience. And if you if you would describe yourself as one of these, then this can be very right for you. An entrepreneur is one that sees an unmet need, identifies a solution, and then executes a plan to bring that solution to market. An entrepreneur is generally tolerant of risk and setbacks in pursuit of achieving meaningful goals. An entrepreneur is one that is never satisfied how things are, but instead always interested in making things better. We all know that the majority of our partners are oftentimes very, very okay to leave things as they are, and there needs to be some in every practice that are trying to make it better. An entrepreneur seeks more out of his or her professional life than the act of working for someone else. So what I would like to go through with you in this talk is, what does it mean to be an entrepreneur? What are the common characteristics of successful entrepreneurs? Why should you consider an interest in this? Why are physicians well suited for this role? Do they bring value to society? Do we have an obligation to foster entrepreneurship? How to increase your chance of success in business ventures? And then some examples. So the common characteristics of successful entrepreneurs you'll see is perseverance, never want to give up, forge ahead in the face of adversity. They're problem solvers. They're leaders, able to organize people. Interestingly, you'll find them empathetic in that they're able to feel the needs of others and want to act on that. They have drive, willing to work harder than their peers, and they have risk tolerance. They're generally creative and optimistic. Optimistic is important. You got to believe that you can do it going into it. So if you have some of these, consider using those assets and doing some good. Why should you consider an interest in entrepreneurship? And number one is the opportunity to improve our healthcare system or improve the lives of patients. Second is the opportunity to diversify your own investments into areas where you have knowledge and control. There's an opportunity to develop ancillary income streams. Many years ago, I was at a lecture and somebody made the point that as an orthopedic surgeon, your revenue is $1 for every $8 that you actually control. That rung to me, and I said, I'd like to control more and in process provide a better experience for patients, better quality, and oftentimes lower costs. So that will take you into medical real estate, surgery centers, medical device innovation in manufacturing, distribution, physical and occupational therapy, imaging, DME, hospital co-management, digital health initiatives. So there's many, many things in our area of orthopedics that we can involve ourselves with, improve our patients' lives, reduce the cost of the healthcare system. Why are physicians well suited for healthcare entrepreneurship? Well, one, we have exposure daily to the unmet needs of the healthcare system, be it access, be it cost, or be it treatment failures. We are qualified knowledge of the industry that's not shared by non-physician entrepreneurs. To get to where we are, we've demonstrated the ability to work hard, delay gratification, we've demonstrated perseverance, and we're able to organize and motivate others. Believe in yourself that you are the best suited for developments in the orthopedic space. Do physician entrepreneurs bring value? Oftentimes there's a shadow is cast over an entrepreneur, and I'd like to bring up now and hit it again that there's really two types. There's those that are interested in improving the lives of others or reducing the cost, or both. And then there's those that are just interested in their own bottom line. And I want to tell you that there's no respect in that. And you'll find yourself a headline in Becker's Orthopaedics if you take that approach. You have to take the approach of improving other people's lives, improving quality, reducing cost, and there's a great role for you. So do you bring value? Yes, provided that your intent is correct. And think about this. When you treat one patient, you help one patient. When you supervise others, you help 2 to 3 patients. Or when you teach residents, you may help many patients. But when you develop a new solution to a previously unmet need applicable to the masses, you help thousands and thousands of patients. So do we have an obligation to foster orthopedic or physician entrepreneurism? I would say yes. Remember, we're positioned to be acutely aware of treatment failures, excess costs, inefficiencies, and dissatisfaction. We see it, and we should, if we're not going to do it, we should support others in doing it and not be those that cast a negative shadow on it. We have to take more ownership of the healthcare system, and investing time and treasure into solutions to real problems is the responsible thing for us to do. No one is better than we are. Now, how do you increase your chance for success? Number one, proper intent. I'll say it a few more times, but you have to have the intent to improve quality or decrease cost. You have to go into any venture in which you as a physician is going to be making money, especially off of any of your referrals. You have to be rigorously tied to proper intent. You need to go into every venture with a disciplined business plan, or if you support a partner and invest in it, you always want to read the business plan. That is the playbook for which it's going to work. And if you don't have a solid business plan, you're more likely to fail. You always want to be honest, and you want to deliver on the promises you made to your investors, because you may be coming back to them in the future. And you want to ensure compliance. Compliance goes back to the first one, which is intent. Let's talk about intent. We have the ability to affect referrals in our business ventures, creating a conflict of interest. These conflicts have to always be managed in the best interest of patients with proper intent and transparency. What is proper intent? Your venture will improve the lives of others and address an unmet need. Your venture will produce cost savings. If it doesn't meet either of those two, then there's a real problem, and you'll find yourself up against fraud and abuse laws. Your business plan starts with an executive summary, a business description. What are the products and services you're going to produce? You define your leadership team. You provide your legal opinion that identifies why it's okay for you to be in this space. You present your operating plan. You look at the competitive analysis and define your growth strategy. You look at marketing and sales plan, and you detail your financials. And if you leave any of these out, you're going to increase the chance for failure in your venture. So I'll take you through a couple of examples of some of the things that I've done. The first, Alliance Surgical Distributors. What was the unmet need? I went the first 10 years of my practice watching the cost of implants increase on average 13 to 15%. There was hospitals had very little leverage in negotiating implant costs. Products were purchased one at a time. Surgeon knowledge and expertise was never used in the negotiation process. Implant companies, on the other hand, had to bear the entire inventory and instrumentation risk, having no way to control it. An implant company passed on a large sales commission cost to the hospital and ASC. The whole thing was very poorly set up, and it led to astronomical prices for the implants. My solution was, let's bring the surgeons with their knowledge and expertise to the negotiation and the purchase of products. My hypothesis was that if we identified like product quality, created competition on price, bought in bulk, both inventory and instruments, and hired the reps ourselves, we could purchase for less than half the current price. That the business plan was to do exactly that. The results were that we developed 14 profitable distributorships that resulted in 36% reduction in implant pricing. This model, however, met, as you would understand, quite the challenge from the incumbent industry, as it threatened the $30 billion orthopedic implant industry that never had to go up and negotiate against physicians. But the model was then further threatened by greedy surgeons. And those two have basically fought us to a draw. But the model can also be used in surgery centers. Stocking distribution for products that you use time and time and time again makes all the sense in the world. And if anybody's interested to talk about it, they can certainly contact me. Your own Chris Contagianis in AAOS Now did a very nice piece on this model, very responsibly showing its value, but also discussing its threats for the physicians that enter it without proper intent. Another company was a orthopedic manufacturing company. The unmet need that I saw was an orthopedic implant company sensitive and responsive to value. The solution, I thought, was to hire experienced engineers from existing companies to focus on improving standard implant designs and develop innovative new technologies while adhering to a value orientation. Funding was personal, friends and family and partners. We designed, developed, cleared and marketed a total hip, a total knee, trauma products, posterior and anterior lumbar and anterior cervical systems. We brought to market very innovative improvements, including the first bearing surface that did not have to compromise strength for wear in a mechanically annealed, highly cross-linked vitamin E polyethylene. And we developed the first additively manufactured standalone lumbar interbody device using EVM technology. And every company now has that. So we brought good innovation to the market while at the same time being the price leader. Last is access health. An unmet need that I saw here was patients access when they needed to be seen with price transparency. The solution, I thought, was to create a mobile app where they could book an appointment, see what it would cost, send their payment, send their PHI, or receive telemedicine, and have an appointment when they wanted to be seen. The funding was personal and family and friends. This interestingly, I had a good track record of success after success until I bucked up against this. And I will share with you a couple of the things I could have done better. The challenges were the provider community was not ready to offer this service, meaning immediate appointments. I think that's changing. I think this idea will find its place. The other thing I didn't realize, because I really kind of let my guard down in my business plan, that marketing in a business to consumer digital business is extremely expensive. That's why you see people out there raising $200 million to do these things. And then software engineers are expensive and hard to manage, especially because it's an area that most of us as orthopedic surgeons don't really understand how coding is done. So what I have done currently is pivoted. And you have to be able to do that at times when it's not working out. You're not going to always have successes, and you have to, you don't give up. You have perseverance. And right now we've pivoted the technology for digital onboarding. In our practice alone, it digitally onboards 50,000 patients a year. We do digital medicine, we do telemedicine, and we do workflow efficiencies in the operating room. I'm going to stay with it. I'm going to make it successful, but it hasn't got there yet. Last is Seven Oaks Surgery Center. The unmet need here was a safe location for essentially all joint replacement procedures and a majority of routine and complex spine procedures. There's a strong push to move joints and many spine cases to the outpatient setting. We have run the orthopedic inpatient service line for the last 10 years and demonstrated a 1.2 length of stay across the board for all joints and all spines. And so we felt comfortable moving this to an outpatient setting, but we wanted to have it in an area that was safe, an area with overnight rooms if we needed to. So we met with a hospital that had a basically vacated outpatient department. They de-licensed it. We opened it as a joint venture with a hospital and majority surgeon owned. And it's the ICU at the hospital is on the other side of the door. So we feel very comfortable to do all the cases that we need to do. We have we went through, developed it brand new. It's a very nice center. It's where I sit right now, having finished a day of 5 spines. We are on track to do 1,080 spine and joint procedures in this new surgery center this year. So those are some examples. In conclusion, in 2021, the United States spent an estimated $12,000 per person on healthcare, the highest in the developed world. For comparison, Germany, which is second, was 7,000, and the average of all the developed countries is 5,000, which is less than half what we do. This is our profession, and quality and cost of healthcare is really our responsibility. Physician entrepreneurship driven by proper intent is the most powerful way to make a difference in thousands of people's lives and a difference in our healthcare system. If you have an idea that you strongly believe will improve quality or decrease cost, please pursue it. If you're affiliated with a partner or colleague that has a good idea and has what it takes to bring that idea to market, support and encourage them. The knowledge and experience that we have as physicians should allow us to do a better job with the development of products and services. Remember that intent matters. Never invest in anything you're not comfortable telling everybody about. Transparency is honesty, and never proceed with or invest in a business without a sound, well thought out business plan. Thank you very much.
John, absolutely outstanding. Very, very cool. And again, your accomplishments as a human being and surgeon should not be forgotten in all you've done.
7:14 p.m.
Sorry. So any comments like John, Kevin, Alan? I see some of our senior members there.
Wonderful talk, John. You make a very compelling argument for why it makes sense for us as physicians to be the ones creating change and bringing value to the marketplace. What advice do you have for those surgeons out there who have an idea but can't get over the hump to bring that idea to fruition, bring it to the marketplace? How do you get started in this realm?
Reach out to others that have done it, other physicians that have done it, because if we've done it before, we have a passion for it and we're charged by it, and we can tell you what mistakes we've made and encourage you and help you with funding and help you bring it, because you need more than yourself always. So I would encourage individuals, if they have an idea, reach out to other physicians that have done it. You will find them, I'm sure, to be very receptive to help you.
Great, thank you.
John Keefe, so thanks for joining us. There are 3 great lectures tonight. I don't know whether you have any questions for anybody. You always have thoughts in all 3 realms: patient optimization, like what Alex has talked about, Bruce Twaddle, stress fractures, you've seen your fair share. And then obviously, John, being an entrepreneur, you were the leader of a very successful group in Spokane. Any thoughts?
They're all great talks. Thanks very much to the speakers, and something everybody, regardless of your specialty, you see all the time. The obesity lecture was germane to anybody who does anything above the wrist or above the ankle, which is a lot. I guess my one concern about the entrepreneurship part is that what we see in our community is the sort of death of private practice. And there's very little motivation when you're working for the man, so I think I applaud what you've done, and I wish more people would do that, because I think it lends such efficiency and it's just better care than what these giant organizations provide. I just am concerned about how people are able to do that when they're sort of shackled into some employed model, which many people are, and increasingly so. Any thoughts? Break the shackles?
Oh,
Don't get shackled in the first place.
yeah. I think again, I'll go back to intent. If the intent is right, you'll get the man behind you, or you'll get the organization behind you. They're going to want to be part of it, and you'll have to look at your contract and see where your intellectual property lies, but they can't control everything that you do. Look at your contract, see what you can do, be transparent with them, tell them what you want to do. If your intent is right and you have a good idea, I think people will support it.
Yeah, John Keefe's standpoint was very apropos. Bruce, you live in a dual world. You're the chief of the Orthopedic Service in Auckland and the university, and yes, you have a very successful sports medicine practice at the same time. I know you're in a different culture in New Zealand, but any thoughts from your dual US and New Zealand purview and how to merge these two spheres?
You mean merging?
Merging in your life, successful entrepreneurship, individual practice with a
So
government
in terms of doing
job.
the trouble is you have great ideas, but inevitably you have time constraints that makes it difficult for you to complete them. So the key is getting a team of people behind you with skills in the area that you need to develop your idea. That's kind of where I see a lot of these things falling over. People have great ideas, they potter in their own office or garage and they never quite get it off. And I really admire the efforts of the presenter and how he has gone through all the steps, and he describes the steps very well as to how you can make success by getting people around you, having a good business model, and that's how you move forward. You can't do it with the power of one person.
Agreed.
We're past time. Shall we ask Kevin, our president, to give us a final word? One word in self-advertisement. We have our mini med school going off. Maybe Angela can throw that in. We're very excited about that. We have 4 camps with about 30 students from the neighborhoods here to try to open up the doors to healthcare, to inspire and educate new people. So if you know anybody who wants to do this, just go to our SSF website, and we're super excited. And anybody who wants to give lectures on this, we now know who gives the best stress fracture talk in the world, but that's a little bit too specialized. But we are gladly looking for people who want to educate high school students on why healthcare is so cool. So thank you all for participating. And Kevin, I'll pass the microphone on to you.
Thank you, Jens. Thank you again for your work organizing tonight, and thank you to the WSOA REOP committee, as well as our speakers, and thanks most of all to those who attended to make this excellent event. So keep your eyes out for our next REOP meeting. Should be taking place in about 3 months. We'll get notices out there beforehand, and let's continue to build this community and continue to support our Washington State orthopedic community. Thanks to everyone.
Thank you very much.